And what we're talking about today is F686. Oh my goodness, F686 used to be F314. They changed the name many years ago. And it's about the regulations and how we need to consider the regulations in the context of clinical best practices. You have to do both, not one, not the other, both of them. And you want to be able to thrive during this survey process. And you cannot do that unless you understand the regulations that frame your clinical practice specifically for wound prevention and management. And by the way, my name is Pamela Scarborough, and I am the Director of Education for Parks Institute, and I'm finishing this 12-month curriculum for United Wound Healing because I love them. And they have done a fabulous job in spreading education to all of you. So with that said, got to make sure my computer's doing what it's supposed to do. There we go. All right, so this is our disclaimer, which I must read. We are being recorded, by the way. This information is provided for informational purposes only. Patient care decisions should be based on relevant clinical guidelines, including current evidence-based literature, state and federal guidelines from CMS, and your facility protocols. Decisions for wound management should be based on a holistic review of the patient's clinical conditions. The clinical team members are encouraged to rely on your training. Where did you get your training for wound prevention and management? You didn't get it in nursing school. Who were your mentors? Where are the books? Where are the courses you went to? What are the regulations that you read? This is a specialty. This is wound medicine. Just like we have to understand many, many things about the other etiologies. A wound that is open and being difficult to close is a problem with the other organ systems. So we have to look at things holistically, and that's what this is saying. The clinical team members are encouraged to rely on your training and expertise, and we've been doing this for 12 months. Somebody has done this for 12 months with us, and you have the basics, the basic standards of practice, the basics on the regulations for you to be able to thrive in this industry in long-term care. So you need to rely on your training, your expertise, as well as any and all information before making any individual decisions for patients and our residents also. Sometimes they're called patients, sometimes we call them residents, depend on where they are in their stay across the continuum of care. So at the end of this presentation, we're going to look at some of the documents. We're going to specifically look at F686, which is the State Operations Manual Guidance for Surveyors, telling the surveyors how they are to look at the clinical practice and documentation that we do in our facilities. We're going to review F686, both from a clinical and regulatory perspective, and then we're going to very briefly mention some other types of wounds that might need to be considered. These are your handouts. You have three. You have your PowerPoint, 2 slides per page in color. This is a visual discipline. Now, F686 doesn't have as many photographs as all of the others, such as your wound assessment, your etiology that we did. You may have more photographs in that, but I do want to say that this is a visual discipline, and you need to know it and learn what you're looking at, and you can do that. You can do that. And then there is something called the pressure ulcer injury critical element pathway from CMS. We have, 20, 25 critical element pathways in long-term care. You want to look at those, and you really want to look at a clinical element pathway from CMS and understand it, because these are the questions that the surveyors are going to ask you. Are the family member? Are your patient a resident? It is the questions to the test. Do not ignore your critical element pathways, all of them, but particularly if you're having issues with pressure injuries and trying to figure out if it's a pressure injury, if it's not a pressure injury, your critical element pathway is going to be an important tool for you. So this is our basic charge in F686, and that is for us to prevent pressure injuries. We're supposed to prevent them. So based on the comprehensive assessment of that resident, the facility must ensure. Ensure is a strong word. Should, ensure, must. These are words that you must pay attention to because they may come back and visit you again, either clinically, regulatorily, or legally. So a resident receives care consistent with the professional standards of practice. Well, how do you know what the professional standards of practice are? It requires this kind of education that you've been going through for a year. to have the information to be able to do this kind of care. You want to prevent pressure ulcers and make sure that person doesn't develop a pressure ulcer unless the individual's clinical condition demonstrates that it was unavoidable. And that means that you have to demonstrate that you have done every single thing that you're supposed to do for the prevention process. For someone who is immobile and they have multi-organ failure, we have to put a care plan in place to prevent a pressure injury. There are some things we can't prevent, and we've talked about that. We talked about the unavoidable pressure injury. That was one of our sessions that we did. So if it's unavoidable, you have to show that through your documentation. And lastly, the third bullet, a resident with a pressure ulcer. The practice standards or the regulations say that they receive the treatment and services consistent with the professional standards of practice. If you have never studied wound management, wound medicine, then you don't know what the standards of practice are. And the purpose is to promote healing, prevent infection, and prevent new ulcers from developing. So it says in F686, it talks about staging, and it says that staging of a pressure ulcer injury is performed to indicate the characteristics, and look at this, the extent of tissue injury. Now, we went through all of this when we did our wound assessment, so there's just a little bit that we're going to do right here, and then I'm going to keep going. So you have to show the extent of that pressure injury, and so you have to learn how to do staging, and staging requires knowledge and understanding of anatomy and physiology, and should be conducted according to the professional standards of practice. Doing your head-to-toe skin assessments need to be done correctly. I was talking to a nurse friend of mine last night. We were working, getting them ready for their board certification as a wound specialist, and he said my nurse in the building only looked at the front and didn't go to the back and look at the back of the head, and didn't look at their back, and didn't look at their sacrum. So we are failing in our facilities, our nurses, head-to-toe nurses, some of them, and it may not be that they're failing. It may be that they don't have time. They haven't been trained. You haven't taken the opportunity to do a competency on your nurses who are doing head-to-toe skin assessments. Have you done competencies? And what we've learned over time is that not all the head-to-toe skin assessments are done appropriately, and that will come back and bite us. So regardless of any staging system or wound definitions used by the facility, look at this. The facility is responsible for completing the MDS, and we have an MDS coordinator on here, utilizing the staging guidelines found in the resident assessment instrument in the RAI, not even what the NPIAP has to say. They want you to stage according to the RAI. We are lucky in that those two documents from the National Pressure Injury Advisory Panel and CMS, they jive. So it's not going to be too much of a problem, but there are a few differences, which brings to the point, we have a new definition that came out for pressure injuries in 2025. Now, CMS did not change their pressure injury definition. They call it pressure ulcer injuries, and National Pressure Injury Advisory Panel caught up with CMS. Not the other way around. NPIP caught up with CMS because they were calling it pressure ulcer injuries all along. They never called it just pressure injuries. And this is why, according to CMS, the pressure injuries refers to localized damage to the skin or underlying tissue, usually over a bony prominence related to a medical device. A pressure injury will present as intact skin. Pressure injury, it's intact, and a pressure ulcer, and may be painful. A pressure ulcer will present as an open ulcer, the appearance of which may vary depending on the stage and may be painful. Now, the next sentence on the left side over here was taken away in 2025 by the NPIP and put in another part of that document. So the new definition is pressure ulcer injuries. Thank you, NPIP, for recognizing the pressure injury that we have that is intact skin. Thank you for that. The pressure ulcer injuries are localized damage to the skin and underlying tissue, same thing as over here, over a bony prominence or related to a medical device resulting from prolonged pressure or pressure in combination with shear. And it goes on to say, thank you, NPIP, that the lesion can present below intact skin, so they're saying the same thing, or as an open ulcer, which may be painful. So we do have a new definition. It's actually the best one we've ever had so far. So when we look at pressure ulcer injuries, and I changed the title on this just a little bit, you have to, again, know what you're looking at. This is just a review for you. Our intact pressure injuries are your stage 1, which you see over here on the left, and your deep tissue pressure injury. Those are the only two pressure injuries that we have that are intact. Then we go to what they're calling a stage 2 pressure injury, which is a partial thickness wound. You must know the difference between partial and full thickness. And at the top, you see a blister, a serum filled blister here. And underneath it, you see where you can see the dermal area. This is not granulation tissue. This is dermal tissue. And you have to learn the difference between dermal tissue and granulation tissue because they look somewhat similar, particularly in color. And then this is a stage 3 full thickness. This is stage 4 full thickness. You know it's a stage 4 because you see a structure. Anytime you see a structure, you are down. Anytime you see a structure, you are always at a stage 4, be it fascia, muscle, tendon, vessels, whatever it is. You see any structures, you are at a full thickness wound, stage 4. Then we have our unstageable, and there are different reasons. Usually slough and eschar are the reasons where we have unstageable. And in long-term care and home health only, we document this blood-filled pressure injury on the MDS as an unstageable pressure injury. That's how we have to report this. My MDS coordinator knows this, and if anything has changed in the last 6 months, you let me know. So we know that this is a deep tissue pressure injury. The MDS has no place to put a deep tissue pressure injury. We also know that probably 90% of the time, 95, 99% of the time, this thing turns into a full thickness wound that goes through all of the layers. So this is a deep tissue pressure injury. When you have a blood-filled blister, you have a deep tissue pressure injury that is full thickness. You want to learn from the MDS. Very important to learn from the MDS also. So prevention of pressure ulcers, this is a major section in F686. Every person that touches that patient, in my opinion, that has a license should read F686, not just for the clinical practice guide that they're surrounding our clinical practice guidelines for our interventions when we have a wound, but also for prevention. And you want to educate your CNAs for their critical role in their pressure ulcer injury prevention. Your CNAs are the most precious people in your building when it comes to prevention. I mean, the nurses are wonderful, the therapists are wonderful, the providers are wonderful. Everyone's wonderful, the dietitians are wonderful. But the people that are seeing that person's skin more than anyone else, touching them, moving them, positioning them, turning them, are our CNAs. Or do we have any CNAs on here today? Empower your CNAs to ensure that you have a functional pressure injury prevention and treatment program. You cannot do it without savvy CNAs. Cannot do it. In F686, there are definitions. These are the definitions. You need to make sure and do competency on your nurses that are going to be doing your wound management, which may be every nurse in your building and the nurses on the weekend. You need to know every one of these. That's another talk for another time. We had this earlier when we did our wound assessment. So does everyone in your building know these? Are on your team that's doing clinical interventions? Does everyone know what these definitions mean and how CMS looks at them and how that dovetails with clinical best practices? How do you know they know them? How do you know they're educated? Are you doing competency? Who should know this information? Who should know these terms? How do you evaluate the knowledge of anybody that's going to be doing wound management? Do you do competencies? A head-to-toe skin assessment. Never assume that your nurses absolutely know how to do it until you've seen them do it. Does your team accurately document these terms that you see? So these are some of the questions. And in F686, it says that that facility must identify whether that resident is at risk for developing a pressure injury from the get-go, from the moment they come into your building and you do your head-to-toe assessment and you start all of the work to get this person into your building. You start looking at those risk factors, particularly related to pressure injuries. What's their mobility? So as we look at this, you want to evaluate their risk factors. There's over 100. We did that, right? We did the risk factors, the Braden and beyond. If you don't remember that talk, go back. The Braden and beyond. We're looking at the risk factors. There's over 100. Changes in the resident's condition. Very, very important. That's telling you something. It can be telling you that this person is going to another level of multi-organ failure, which is going to impact healing and or the development of pressure injuries. You want to implement, monitor, and modify the interventions to attempt to stabilize or reduce or remove the underlying risk factors for a pressure injury. If that pressure ulcer injury is present, then you have to provide treatment to heal it and to prevent the addition of other pressure injuries. Now, this last sentence, you cannot do this, nurses, by yourself. Thank goodness for wound providers that are beginning to come into our buildings. It has made such a difference when you get a good company that has trained their wound providers well. And so note, if prevention is not possible, And there are people that you cannot prevent skin breakdown because their organs are breaking down. The provider should assist with documentation of why that resident may be at risk for an unavoidable pressure injury. Get your provider, get your medical director to be part of your team. If healing is not possible, then the provider needs to assist and document why healing is not possible. What are the ICD-10 codes that correlate to non-healing of these pressure injuries? Pressure injuries are on the spectrum of organ failure. There will not be pressure injuries if there's not organ failure. Now, we were having a discussion one day, a couple of my nurse buddies, about, well, what about the eyes and what about the hearing? Well, you might be able to bring that in, but I'm talking about primarily the internal organs, maybe not the eyes so much, but the brain is one of them too, by the way. So we're supposed to identify the resident at risk for pressure injuries and then put together an individualized care plan for doing the interventions and the monitoring for the effectiveness of those interventions. So the risk assessment criteria, this is what we have to do. You have to do our risk assessments, and we have to look at the risk factors. You have to remember there's over 100. There's not 6. The Braden is insufficient. The Braden is insufficient, nurses. There's not 6. There's over 100 risk factors. The 6 risk factors are what Dr. Barbara Braden wrote for that nurses could intervene for. Those 6 things are the 6 things that nurses, according to Dr. Braden, could create interventions for. The providers are going to be doing a lot of the other work. And we have to remember that if you're trying to take all of this on yourself, nurses, you're setting yourself up for failure. You have to have your providers involved in this also. So you have to look at your pressure points, tissue tolerance. Everybody has different tissue tolerance, nutrition, hydration, moisture, urine and feces. We talked about this. So all of this is important for your treatment. And you need to get this done from the get-go. Now, where we're going to go right here is we're going to start talking about present on admission and multi-organ failure, because all of this has to do with pressure injuries. So the risk assessment. On admission, the admission evaluation, you are to identify residents at risk of developing a pressure ulcer injury and residents who currently have existing pressure ulcer injury. So this speaks to the component of your present on admission. If they have any wounds, any skin openings at all, wherever they are on the body, you are going to document them. You're going to assess them and document them, which means you're looking at them. You're looking at this person from their occiput all the way down to the heel and every place in between, front, side, and back. Then the risk assessment, the residents at risk that they can get a pressure ulcer injury within hours of onset of pressure. And pressure has to do with reduced mobility, or it has to do with medical devices. At-risk residents need to identify and have intervention implemented promptly. You should have something in place within 24 hours to attempt to prevent the pressure ulcer injuries, and the admission evaluation is going to help define your care plan approaches, of course. Admission evaluation may identify pre-existing conditions. Many of these people are coming to you either with wounds or with pre-existing conditions that are going to cause wounds. As soon as they go immobile, their risk goes up 100-fold. As soon as they go immobile, they're at risk before then as they're in organ failure or organ dysfunction. But as soon as they go immobile, you've got something that you're going to have to take care of. So pre-existing signs suggesting tissue has already occurred and additional tissue loss may occur. This speaks to present on admission. A deep tissue pressure injury may be identified on admission, but that deep tissue pressure injury in our care setting is probably going to turn into a deep stage 3 or stage 4, because that deep tissue pressure injury is already a full thickness wound. You have blood, you have bleeding at the muscle level. That's where that blood came from the muscle level. Know your anatomy, know your physiology. A stage 1 pressure injury, it says in the guidelines, can progress to an ulcer with eschar and exudate within days. Again, we're speaking to present on admission. Some situations which may have contributed to this tissue damage prior to admission include, look at this, pressure resulting from immobility during the hospitalization, a surgical procedure, or look at this. This was wonderful. During prolonged ambulance transport, this has happened. My grandmother almost ended up with this. We had her in an ambulance from Louisiana to North Texas. I wouldn't leave her in a nursing home in Louisiana. I couldn't in my heart do it. Texas was a little bit better, so I brought her to Texas, and she got a stage 1 on the way here and told me never to put her in in a station wagon. Again, it was an ambulance is what it was. So, immobility during hospitalization, during prolonged ambulance transport, or while waiting to be assisted after a debilitating event, such as a fall or a cerebral vascular accident where they may fall or something along that line. And some people are laying in their homes. They've fallen, they can't get up truly, or they've had a CVA or some other event. And when they fall in their home and they're there for several hours, oftentimes they come to us in long-term care with something that's going on with their skin. So the risk assessment, this is CMS's perspective on the risk assessment, and this is for our providers. So note the providers' help is needed that with the medical assessments to document the counsel to the family and residents. We've got to have those ICD-10 codes for all of those other comorbidities to identify why this resident has an unavoidable or non-healing wound. So this assessment, CMS says the assessment also helps to identify which residents, so important, remember the skin failure talk, this was in that talk. It talks to us in the regulations about more multi-organ, multi-system organ dysfunction and failure, which is part of the end of life situation, which is part of the unavoidable pressure injury situation. This speaks to unavoidability. Who's refusing care? They have the right to refuse care, but you better be documenting that they refuse the care, that you talked to them about it, and that you gave them an alternative plan if they would do it. Document when they are refusing. And lack of documentation on these issues causes survey and or legal issues for facilities. And when your company is paying for legal bills, that takes money away from what you can have. So we want to make sure that our companies don't get in trouble because of what we do or don't do, so that they don't have to pay for legal situations that take away from the bottom line for what we may be able to do for personnel. And I don't know that for sure, but if we're spending money someplace, a lot of lawsuits means that we don't have the money to spend someplace else in our corporations. So CMS, this is fabulous. This is so important. Not all risk factors are fully modifiable or can be completely addressed. That needs to be documented, and it speaks to unavoidability. Some risk factors, such as permanent lack of sensation for people with diabetes, with peripheral neuropathy, may not be modifiable. You can't change that, but that speaks to unavoidability. They can't feel it. They can't talk to you. So you have to do something special. That skin is seen all the time when your patient can't talk to you and tell you that they hurt. Some potentially modifiable risk factors, such as malnutrition or uncontrolled blood glucose, may take time to correct despite prompt intervention. So this is care planning. This is about care planning. Other risk factors, such as pressure, can be modified promptly. Put in our pressure redistribution devices, be it a seating device, a bed, a turning schedule. All of these things go in place. You document it. Many studies and professional literature identify risk factors that increase a resident's susceptibility to develop or to not heal. CMS recognizes this. Use this recognition to your benefit. Resident susceptibility to develop or not heal pressure injury. So again, this speaks to the unavoidable or unhealable pressure ulcer injury, and we need our providers to document those ICD-10 codes for every organ that is impairment, and nurses, you need to recognize that. There may be more than nurses on here, by the way. I shouldn't say that. We could even have providers on here, or PTs. If there's any PTs or providers, please let Jacqueline know. I'd love to know you're here. All right. Now, this comes out of F686. This is the list of things that CMS says that these are risk factors they include, but they're not limited to. Impaired mobility is at the top of the list. The comorbidities are at the top of the list. Not moisture, not some of the things that we have on the brain. And some of them are on here and some of them aren't on here. So our drugs, steroids particularly, impaired diffuse or local blood flow. This diffuse blood flow, that's your cardiac. What's going on with your cardiac output? None of us know. We don't get those cardiac output numbers. We don't get how much percentage of cardiac output we have, and we should. You can't assess systemic blood flow unless you understand cardiac output and ejection fraction. So what are that's diffuse. Then our local blood flow is like the peripheral arterial disease to the lower extremity. They can refuse care. We talked about that. Document. Sensory perception, cognitive impairment. The brain is a big deal. When the brain starts to go out, mobility begins to change. And these people end up immobile when we go into dementia and it gets towards the end stages of Alzheimer's and dementia. Your nutrition, hydration impairments. This is pulse ox. Look at your pulse ox. If you've got a pulse ox at 92%, you're going to have diminished opportunities for wound healing. What does your pulse ox say for that particular person? Look at your bony prominences. Have you taught your CNAs all the bony prominences that they need to be looking at and be doing their daily skin assessment when they're bathing them or changing their clothes or cleaning them up? And this is what all of our nurses need to be looking at for present on admission. These are the primary bony prominences. And our CNAs need this information also. It talks in the guidelines about seating. Just it talks about how at risk the ischial tuberosities are for people who don't have chair mobility or wheelchair mobility, slouching in the chair, particularly when their back muscles are weak, and they're going to have pressure on that thoracic spine area, the scapula, the elbows. Look at this lady here. Her elbows here is going to cause a problem for her. And look at her. She can't breathe. This one, she can barely breathe. She can breathe a little bit. All right, I'll give you that. She's down like this. Her right lung is collapsed and cannot do a full inhalation because she's collapsed down here. What's her pulse ox? Think about oxygen all the time. When you're thinking about wound healing, think about oxygen all the time. Wound healing doesn't happen without oxygen. Wounds will be acquired more easily with diminished oxygen. So look at that systemic oxygen. Use your pulse oxes. Friction and shear are important factors in tissue ischemia, necrosis, and also pressure ulcer formation. Shear, one of the things about shear, for instance, if I'm having shearing, we see shearing a lot on the sacrum. Oh, excuse me, let me go this way. We see shearing a lot on the sacrum. So when you see, I've got undermining from 10 o'clock to 2 o'clock. You can see my finger going in here. You've probably all seen the Seymour butt model. This is from shearing. This is from this person laying in the bed. We bring the head of the bed up, and when we bring the head of the bed up, the skin sticks, the underlying tissues slide down, and you get shearing at the top of the sacral area. So that's telling you that there needs to be some changes in how you're going to elevate and how you're going to position this person. And is your rehab team helping you? Rehab needs to be involved. Rehab needs to be involved right there. They get some training on this. Now, I do have to tell you, when it comes to seating specialists, that is another specialty in PT and OT in rehab. And people go back into training to be a seating specialist. Every single company that gives you or sells you seats will have a seating specialist working for them. If you don't know how to do this, if the therapists don't know how to look at this and get this person seating where they can sit up, now they could just be sleeping and need to go to the bed. But if this is how they sit at the nurse's station, there needs to be an intervention. There needs to be an intervention. And is your rehab team helping you? Are the providers in nursing requesting? Are you requesting rehab? Nutrition and hydration is absolutely critical. One of the things, we're having a meeting right after this for the skin failure special interest group. And one of the things that we specifically went out looking for was a dietitian, nutritionist who understood wounds. Not just a nutrition diet, just like a physical therapist. You want a physical therapist that knows wounds. If I'm going to be talking to you and working with you, I want a nurse that knows wounds. I want a doctor that knows wounds. I want a dietitian that knows wounds, because it's different. The protein that the people have to have, it's different. And there are guidelines for this. So when we look at nutrition, it affects prevention of these pressure injuries and wounds. And it can be an impairment to healing if they're not getting enough uptake. And there are many reasons that people don't get the uptake they need. So the question is, are the providers and the facility staff assessing all the organs and organ impairments that can put this person at risk, including nutrition? And you're not just looking at albumin. Albumin is really not what you want to be looking at for nutrition. I look at albumin, I'm thinking more about the liver, to be honest with you. If there's a problem with the liver, that tells me that we're going to have problems with healing. So you want to look at your pre-albumin, and that's another talk for another time. Nutrition and hydration now. Weight loss is a problem with wound healing. You don't want your patients and residents losing weight while they are trying to heal. And this weight reflects this balance between intake and energy. And when you have a wound, particularly a large, deep wound, such as a full thickness stage 3 or 4 pressure injury, the body requires more protein. So all of your patients and residents should be on extra protein of some type because they're not getting enough. When you have large wounds with a lot of exudate, you're losing a lot of protein out of that wound that they need for wound healing, for that open wound. So significant unintended weight loss may indicate undernutrition or a worsening health status. Look at this weight loss. Small weight loss over weeks tells you they're a problem. Look at these incremental weight loss. This person is now going into another level of organ dysfunction if they are continuously losing weight and or they are not getting enough nutrition, particularly calories and protein. Residents with pressure ulcer injuries who continue to lose weight either need additional caloric intake or correction where possible. And it's not going to always be possible. It's not always possible. But you want to document that you tried. You want to document that you tried. Of conditions that are creating this hypermetabolic state. Continuing weight loss and failure of a pressure ulcer injury to heal despite reasonable efforts to improve caloric and nutrient intake. Here we go. CMS is saying this. I'm not saying it. The attorney's not saying it. The provider's not saying it. CMS is saying this. Continuing weight loss and failure of a pressure ulcer injury to heal despite reasonable efforts to improve caloric and nutrient intake may indicate the resident is in multi-system failure or an end-stage or end-of-life condition warranting additional assessment of the resident's overall conditions. So providers, nurses, when you see a trend in weight loss, you don't keep it just in your documentation. Oh, they lost another quarter pound. Oh, they lost another. It's not just in your documentation. You notice a trend. You're calling the provider or you're going to your medical director. That is a sign that that patient is in trouble for either acquiring wounds or for non-healing of the wounds that they have. Watch weight. Take weight seriously. It's not a minor thing. It's a major thing. In F686, it talks about moisture. Both urine and feces contain substances. They contain enzymes, particularly feces does. Anything that ends in ASE, as you know, breaks tissue down. Anything that ends in ASE. And there's a lot of ASEs in feces. So fecal incontinence may pose a greater threat to skin integrity due to the bile, acids, and enzymes in the feces. And here's the deal. It is so critical that our nurses are and I've been known to clean up poop. I'm a physical therapist. I will clean poop because I know this. If you leave any poop behind, say you just are doing wiping with a washcloth only, warm washcloth. I've seen that. Wipe with a warm washcloth. But now I think we're doing wipes more, and those wipes have surfactants. But it's critical you get every bit of that feces off the skin, because if that person has urinary incontinence and that urine gets back on the feces that's sitting on the skin, sitting right there at the anal opening, at the anus, that urine reactivates those detrimental enzymes and it burns and there's pain for that person. If they're saying my butt hurts or my anus hurts, they're telling you that they're not getting clean enough. Or there could be some other problems, but it's going to be an inflammatory issue usually. Irritation or maceration resulting from prolonged exposure to urine and feces may hasten skin breakdown, and moisture may make the skin more susceptible to damage. That's your maceration, of course. Prevention in F686, the comprehensive assessment should provide the basis for defining the approaches to address the resident's risk of developing or already having a pressure ulcer. This was interesting when I read this in F686. It says a determination that a resident is at risk. You've said the resident is at high risk or moderate risk or low risk. You've said they're at risk for a pressure injury. So they're at risk for developing this pressure ulcer injury. It has significant implications for prevention and treatment. But just because you documented that they are at risk does not indicate that that pressure ulcer injury was unavoidable. You had to show you had all of the pressure injury prevention strategies in place before you can call unavoidability with that surveyor. So overview based upon the assessment and the resident's clinical condition, choices, and identified needs. Basic or routine care should include, but is not limited to, pressure redistribution. So this is your mattresses and your seating devices. Minimize moisture exposure and keep that skin clean. This is a big deal. This is really on our CNAs and certainly on our nurses, our bedside nurses, especially a fecal contamination. CMS brings up fecal contamination again. Provide the appropriate pressure redistribution support surfaces. Provide non-irritating surfaces. We have new sheets new textiles that come out that really do make a difference. And some of them are kind of slickery, and that person can slide on it a little bit better than the old polyester things that are so hot and make these people sweat and actually make the skin more vulnerable because it's hot. You want to maintain and improve nutrition and hydration where feasible. Where feasible. CMS recognizes that, and they say where feasible. Adverse drug reactions related to the resident drugs regime. Are they on anticoagulants? Are they on steroids? What are they on that can worsen the risk for development or non-healing of pressure injuries, particularly steroids, corticosteroids, for example, by causing lethargy. So that's something that's going to relax them, or anorexia, where they're not going to want to eat, for creating or increasing confusion. Some of the medications do that. Some of the pain medications do, and should be identified and addressed. So which drugs, and there's a list of them, are complicating the healing opportunities, and your providers should be looking at that drug list. You might want to ask the providers, do you see any drugs that could be impairing healing? And if they say, well, I don't know, they need to figure that out. Particularly if they're a wound doc, you've got a wound provider group coming in. They need to know this information. All right, so repositioning, there's a whole section on repositioning. Please be sure that the CNAs, the nurses, and the therapists, PTs and OTs, read this section. There's a whole section on repositioning, and it's very well written, but it is written specifically for all of us that are moving the patients. It's not all that much for the dietitian, not even for the provider, except to write the order that it be done. So repositioning is critical for a resident who's immobile or dependent on the staff repositioning. We know that. You also, if they can't make small movements, they can't make any small movements, then we're going to have to put in a device or a timing, a care plan that has a timing going on for us to take them off of their bony prominences when they need to be, whether they're sitting or whether they're lying down. So positioning the resident on an existing pressure ulcer, of course, should be avoided if you can. But sometimes we have people with pressure injury ulcers on 2 or 3 turning surfaces. So note, this work speaks to everyone involved in repositioning, but especially it speaks to the CNAs, and they should have been taught repositioning appropriately. So you want to determine the repositioning frequency with consideration to that person's level of activity, their general medical condition, the overall treatment objectives. Is wound healing what we're going for? Is this palliative care? Is this hospice care? And all of this makes a difference, and all of it needs to be documented. Their skin condition and their comfort. So there's much more guidance statements on repositioning. We don't have time. I'm skimming F686, getting some of the things that are deep in this document to help you. But this is an overview of F686. Please read the entire section for repositioning. Ensure your rehab team also reads, and ensure the CNA are aware of the repositioning guidance. Here's your support surfaces. Either it can be a bed, mattress, it can be a seating device. This pressure redistribution refers to the function or ability to distribute that load over a surface or contact area. And we want to try to match that device for the therapeutic effect with the resident's specific condition. Are they obese? Are they big people? Are they 6'7"? We have to have a different bed if they're 6'7". Does what you're putting this person on work? I recently had a young man who had an amputation, and he's a big man, big hips. He had an amputation of his right leg below the knee, and he was given at a facility a regular wheelchair that was too narrow for him. He got a pressure injury because the wheelchair didn't fit, and they didn't put a cushion in for him. So he got a pressure injury. This is important. Hopefully somebody's looking at this in your buildings. And this effectiveness of the pressure redistribution device, such as your Dell mattresses, air fluidized mattresses, low air loss mattresses, is based on their potential to address that individual's risk factor. So not every one mattress or every one seating device is going to fit everyone's circumstances. And how are you going to work with that? So the surveyors, now this is a note to the surveyors, and it's talking about support surfaces, and says that the surveyors should consider the following. And there was a building that they got, and they didn't get an F-tag. The surveyor gave them grace, but the bedside nurse had been in the room working with the patient. The surveyor was following them, the nurse. And when the nurse came out of the room, the surveyor said in private, Why do you have this person on this type of bed? What is it about this bed that is different? And the nurse didn't know what to say. They didn't know about pressure redistribution. They didn't know about microclimate. And we need to know these things. These are important, and this information is in some of the other talks that we did. So, do you have a static device, pressure redistribution device, or is there a dynamic device? Some of these beds literally will help this person. They're so immobile, they cannot roll, and they are so fragile. They need to roll frequently, that we can get beds that will take them to side lying at 30 degrees, supine on their back, side lying at 30 degrees, and we'll do this as much or as often as we program it in the computer for the bed. So dynamic pressure injuries, the resident can assume a variety of positions without weight bearing on a pressure ulcer. The resident completely compresses a static device, so we might need one that's going to move. And the pressure ulcer injury is not healing as expected, and it's determined that the pressure may be contributing to the delay in healing. So then you may have to go to a higher level device. And again, that's going to depend on your care setting. Monitoring in F686, it says that you need to be monitoring the skin. The staff should remain alert to potential changes in the skin condition and should evaluate, report, and document these changes as soon as you've identified it. This talks about a resident complaining about pain and burning at a site where there's been pressure, or observed during a bath when the CNA is bathing them. So this may need to be evaluated further. Take every bit of that information. You don't want to say, oh, I'm too busy. I know you're too busy. You don't want to say, oh, we don't have the tools. We don't have the resources. I know you don't have all the tools. I know you don't have all the resources. But some of the things that you can do, and you can look. You can go look. Please remember the CNA is a critical team member. I know I've stressed that a lot. Can't say it enough, I don't think. Assessment and treatment of pressure ulcer injuries in F686. It says it's important to recognize whether it's present on admission or developed after admission, and that makes all the difference in the world to you. Did they come in with this pressure injury, or was it developed in the facility? What's happening a lot of times is you didn't know that they were in multi-organ failure. You didn't start their pressure redistribution stuff early enough. That's why they were in the hospital. They got them stabilized. They're not cured. These people aren't cured when they come to the hospital. They still have the same illnesses. They still have the same organs that are in failure. They've just got them stabilized, send them to you, and you don't have the resources to stabilize them. And they go downhill again, and then they go back to the hospital. So all of this information, if it's all documented, you can show cause for why we are having rehospitalization. It's because this person should no longer be in this building. They're too ill. You want to ensure the intake team is thorough with the skin assessment, and please read Section M in the MDS. Please read. That's great education. In the minimum data set, please read that document. It is precious to you. Assessment and treatment of pressure ulcer injuries. When assessing it, this pressure ulcer injury, we have to document the type of injury, the etiology, and please, and we did a talk on this. Pressure injury imposters. We are reporting things that are not pressure injuries as pressure injuries. Do not default to pressure injury if you don't know what the etiology is. You default to something else. You default to chronic wound. There is an ICD-10 code for chronic wound. You don't know what that chronic wound is. The provider doesn't know what that chronic wound is. I've worked very closely with providers. They don't get the etiology correct oftentimes until they've done some testing and they looked at lab work. They've done their blood flow studies. And then we'll get the correct etiology. So having the correct etiology is, if we don't have the right etiology, we're not going to get the right intervention. Pressure ulcer staging, there's so many mistakes on staging from the physicians, the nurse practitioners, the physical therapist, the nurses. There's so many mistakes on staging. And when we make a mistake, it puts you at risk for other issues. A description of that pressure ulcer injury. This is your wound assessment. This is where we're talking about the wound assessment. Progress toward healing. You want to identify this through your measurements. You know whether healing or not. That wound is healing through the measurements. The measurements are telling you how well this wound is doing every week. Measurements must be done weekly in long-term care. No exceptions. No exceptions. No exceptions. That is a regulation. We have to do our assessment weekly for our wounds. For pressure injuries, and you should do it for all wounds, through your weekly wound assessment. If infection isn't present, You got to take care of it, whether the pain was there and what did you do about it and did you document it, and a description of the dressings that you use, what category of dressing, what size dressing, and what other treatments that you may have done, including wound cleansing. In F684, you want to go back and look at F684. If you're going to do wound management long-term care, you want to look at F684. F684 describes mentions four other types of wounds. And it talks about arterial insufficiency, venous insufficiency, and diabetic neuropathic foot ulcers. And F684, which is the quality of life tag, is the first time they mention the Kennedy's terminal ulcer. It's mentioned in F684, and they tell you to go to F686 for more information. So these are three, and it's in F684. Three of the most common types of skin injuries are pressure, vascular ischemia, venous stasis, and arterial ischemic. So this is venous and arterial. Two different etiologies in the vascular system. One's in the venous system, one's in the arterial system. And we did this talk when we went through etiologies. At the time of the assessment, the clinicians, the physician, advanced nurse practitioners, physician assistants, certified wound specialists should document the clinical basis. Here you go. The type of injury, where is it located, what is the shape? This is irregular shape for venous insufficiency. Irregular is for venous insufficiency. Round punched out is for arterial insufficiency. Diabetic neuropathic foot ulcer, that's what you're seeing on ambulatory patients only. They don't happen on the top of the foot. They don't happen on the heel. They don't happen up in the leg. Diabetic neuropathic foot ulcers are only happening on the bottom of the foot of people who are walking. They might get a blister on their heel, but that is a blister. Diabetic neuropathic foot ulcer has to do with pressure and shear. Same thing for pressure injury. So, and you have to document, according to F684, the type of skin injury, what's the etiology, what's the location, what's the shape, what are the edges, are they attached, are they unattached, what's the wound base look like, is it viable, is it non-viable tissue, is it not pressure related? And you do this, especially if the injury has characteristics consistent with a pressure injury, but is determined not to be one. They're asking you, please don't report wounds as a pressure injury that are not a pressure injury. They don't want you to do that. So can your team, and you've all seen this, if you've been on for 12 of these, you've seen this. Can your team in your building identify these 5 bottom etiology for their wounds? Oh, darn. Well, I have the names of them here, so it doesn't matter. They're all 5 are something different. That's moisture-associated skin damage. Deep tissue pressure injury is the second one from the left. Kennedy terminal ulcer is the third one in the middle. This is a chronic tissue injury. This is a different etiology. This is, we think it is blood coming out of the venous system. We see it in people that are more immobile, but it is not a pressure injury. This is chronic tissue injury. It's a different animal. And they can get pretty severe, but they're not related to pressure per se. And then this is COVID-19 skin manifestations. We were having this all over the place, and it was from the coagulopathy issue. So that's another talk for another time. And we're not having the coagulopathy issues with COVID now the way we did in 2020, 2021, and early 2022. As the disease got less virulent and less harmful to us, this particular coagulopathy issue diminished. Stage 2 pressure injuries. This is one of the biggest mistakes that we have in staging. People call stage 2, they'll call it stage 3. They'll call it stage 2. They'll say it's a stage 2 with slough. There's no such thing. Stage 2 is partial thickness wound. So there's not a stage 2 with slough. There's not a stage 2 with granulation tissue. That's a full thickness wound. So in F686, it says, and it goes through staging. The state operations manual guidance to surveyors goes through staging, as does the RAI. That's your MDS, your minimum data set. You have to use those staging definitions. So stage 2 pressure ulcer is partial thickness with exposed dermis. That's what you're seeing here, exposed dermis, or it can have a blister. And it talks about the wound bed is pink, viable, red, moist, and it goes on and says granulation tissue, slough, or eschar are not present. This is in our definition in the RAI. Do not let a provider code slough in a stage 2 or granulation tissue in a stage 2. You bring them the regulations. You do not let the providers put you at risk for F-tags because they don't know our regulations, and they don't know our regulations and don't understand what it means to us. So this stage should not be used to describe moisture-associated skin damage, including incontinence-associated dermatitis, intertriginous dermatitis, or medical adhesive-related skin injuries, traumatic wounds such as skin tear, burns, or abrasions. And so these are, if this is MASD, this is not a pressure injury. These are intact pressure injuries. Stage 2, these are both stage 2. So daily monitoring, we have to do daily monitoring. There needs to be something that you said, the CNA said that the skin was intact. We are told it's important that the facility have a system in place to assure that the protocols for daily monitoring are in place with periodic documentation of the measurements, which are weekly in long-term care. You need to know your terminology, some of the terminology that I've talked about. The frequency of the assessment should be done. You know when it's done. On admission, 4 weeks for the first 4 weeks, quarterly, and anytime there's a change in condition. You know when you have to do your reassessments. And documentation are implemented consistently throughout the facility. So my question to all of you is, how are you monitoring your pressure ulcer injuries daily? I'm not telling you to do it. The federal regulations are telling you to do it. So daily monitoring, when a pressure ulcer injury is present, we have to have accompanying documentation. We need to evaluate the status of the dressing. If it's present, if it's not present, is it leaking? Is it not leaking? And that's something the CNA, that's a CNA duty. It's a nurse duty, certainly, but the CNAs are going to see the dressing much more often than you are. Status of that area, that surrounding area, that peri-wound area that you can see without removing the dressing. If you're getting redness outside your dressing, well, maybe we need to take the dressing off and see if we have an infection taking place here. Presence of complications such as signs of increasing area of ulceration or soft tissue infection. For example, increased redness or swelling around the wound, or increased drainage from that wound, and whether pain is present and whether it's being adequately controlled. So this is what daily monitoring should look like in your building for your pressure injuries, whether they were present on admission or whether they were facility acquired. And then observation, here it is in black and white for you, with each dressing change or at least weekly in F686, and more often when indicated by wound complications or changes in wound characteristics. An evaluation of that pressure ulcer injury should be documented, and at least we have to do this location. Where is it on the body? Where's the anatomical location? What stage is it? What size is it? We have to use our measurements. Vertical, 12 to 6, 3 to 9. We don't do it like they do in outpatient wound care, where they go the longest length, say it's from 2 o'clock to 7 o'clock. We don't do it like that. 6 to 12, 3 to 9 at the widest area. That's how we have to do it in long-term care. So you're going to do the depth. Is there any undermining sinus tracts? Those need to be documented, recognized. You have to have the knowledge to recognize a tunnel or a track and document it, measure it. Define where it is on that patient's body, and then you document the characteristics, which includes you have to do your tunneling, your sinus tracts, your undermining, your exudate. Is it purulent? Is it serous? What quality exudate do you have? What quantity exudate do you have? The quantity of the exudate drives your dressings. Drainage drives dressing decisions. D. I am a low-level poit. Alliteration is the lowest level of poetry that there is, and that is me. Pain, if it's present, and then the wound bed, the color of the wound bed, the type of tissue, the character of the wound bed. Is it granulation tissue? Is it necrosis? And if it's necrosis, is it slough? Is it eschar? Description of the wound edges. Are they rolled? Do you have epibole? We talked about every bit of this when we did your wound assessment session a couple of months ago. Healing of pressure ulcers. Now, this is in section M, and it's so important that you put these two documents together to help you understand wound prevention and management in long-term care. You put both of these documents together, F686 and the MDS section M in the resident assessment instrument. So it says, ongoing evaluation and research has indicated that pressure ulcer injuries do not heal in a reverse sequence, and then blah, 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 blah. So that means no backstaging. Believe it or not, last year I had a physician that told the building to backstage, and the building held firm and would not do it. It's in our regulations. Do not let a provider who doesn't understand our regulations put you at risk, put your building at risk. Here it is in the regulations, no backstaging, specifically mentioned in section M. And facilities are required again to use the resident assessment instrument that has the directions for describing your pressure ulcers, and how we're going to be coding them. It also helps you with coding. And we have some problems with coding when it comes to skin failure, and we all know that. So great education in section M of the MDS. Seating guidance, are you doing this in your buildings? In F686, it says that the residents should be limited to seating 3 times a day for periods of 60 minutes or less. Are you leaving your people in their chairs that have immobility, chair immobility, for 3, 4, 5 hours? That's a problem. Going to get an ischial pressure injury. And you need to consult a seating specialist that we talked about. Encourage shifting in their chair as you walk by, you walk in, and get the CNAs. The CNAs need to learn this also. You want to modify the seating time schedule, reevaluate the seating surface and the individual's posture. That posture makes a difference. If this pressure injury worsens or fails to improve, this device can be part of the problem. Failure to heal. It says if a pressure ulcer injury shows some progress of healing within 2 to 4 weeks, the area and shows progress toward healing within 2 to 4 weeks. It should show progress within 2 to 4 weeks. And if it doesn't, then we have to go back and do an assessment. And that's where the providers are absolutely essential to help us with why aren't our wounds closing? You've got to have those providers. You want to have reevaluation of the treatment plan by the provider, determining whether to continue or modify those interventions. And again, it's going to depend on that person's condition, and the results are going to vary also. So clinically complex patients and wounds, clinically complex patients and residents will have limited wound healing. Clinically complex patients and residents are going to have some limitations, usually with their wound healing. That complexity of the resident's condition may limit the responsiveness to the treatments or tolerance for certain treatments or modalities. This speaks to the unavoidability for non-healing situations due to multi-organ impairments or other conditions preventing healing, such as severe peripheral arterial disease in the lower extremity or end-stage congestive heart failure, where you're not getting that cardiac output that we don't know how much it is, by the way, that ejection fraction. So the last thing we have to say here, buildings will receive an F-Tag for wounds that are not showing evidence of healing. You can get an F-Tag. You're doing everything you're supposed to be doing, everything that the provider said to do. You can still get an F-Tag if you didn't document why it's not healing. So we can get an F-Tag if these wounds aren't healing for extended amounts of time, such as months, unless we've documented the clinical or other regulatory recognized issues that speak to the inability of that person's body to heal the wound or non-adherence by the resident. That can be a problem. It's often a problem to the care plan, which has been thoroughly documented. So the clinician, if you're going to keep doing that same regime and this person isn't healing, then you have to say why. And the provider should do that for you. Again, this is where you must have your providers or medical directors involved in identifying, documenting, and reporting the ICD-10s, the complicating conditions that can stop or stall the healing processes. Improvement and compliance of pressure ulcer injuries. Pressure ulcer injuries may progress or may be associated with complications such as infections, which is cellulitis, bone infections, osteomyelitis, infection of the joints, septic arthritis, abscesses, bacteremia, septicemia, chronic inflammation, or the development of the sinus tract. Sometimes these complications may occur despite improvement of the pressure ulcer itself. So note from CMS, this is from CMS, the physician's involvement or the provider. They haven't started using the word provider yet. They'll catch up. The provider's involvement, but I do what CMS says when I'm reading this stuff to you. The physician's involvement is integral whenever significant changes in the nature of the wound or the overall resident's conditions have been identified. This is about, again, the investigative protocol. It tells the surveyors, your critical element pathway tells the surveyors what they're supposed to do. These are the questions to the test. This is the survey. Ensure you frame your pressure ulcer prevention program and interventions with these questions in mind from the pressure ulcer critical element pathway. Specific provider considerations. Now, this is looking at your providers. And one of the things that they say in this document, did the physician evaluate and assess the medical issues related to the resident's skin status and supervise the management of all medical needs? Now, that's part of what your medical director is supposed to be doing, I think. including participation in the comprehensive assessment process, development of a treatment regime consistent with the current standards of practice, monitoring and response to notification of change in the resident's medical status, blah, blah, blah. And if the physician isn't involved, then the building, not the physician, the building gets an F710 tag. So is the facility medical director or medical management teams assessing and supporting the wound management medicine program at the clinical level that enhances the wound healing outcomes in people that are not on hospice care? For people not on hospice care, are the patients and residents' health reviewed holistically and the wound regionally and locally? So we look at things holistically, then we go regionally, then we go locally when we do our assessments. Key elements of non-compliance: the facility failed to provide preventive care that was appropriate. They failed to provide the appropriate treatment interventions, and the facility failed to ensure that a resident did not develop an avoidable pressure ulcer injury. Also, it's not necessary to, these are the times that you're going to get those F tags, when they think you failed to do your due diligence. So summary of skin integrity from the surveyors. You want to briefly review the comprehensive assessments, the care plans, the physician's orders. This is all what in the regulatory guidelines, what the surveyor is going to be doing with you. So they're supposed to identify the resident at risk for pressure ulcer, evaluate the resident's pressure ulcer injuries, and intervene to prevent and or heal pressure ulcers. During this review, this is the instructions to the surveyor. The surveyor is to identify the extent which the facility has developed and implemented those interventions in accordance with ensuring a resident receives care consistent with the professional standards of practice, which is the minimum standards. It's not what they could do. It's not electrical stimulation. It's did you prevent all the things that you needed to do and do the cares that you needed to do. It's the standard of practice, the minimum of what we're supposed to do. This information will guide observations and interviews. And we're almost done. It's important for the surveyors to understand that when a facility has implemented individualized approaches for end-of-life care in accordance with the resident's wishes, development, continuation, or worsening of a pressure ulcer injury may be considered unavoidable. This is the Kennedy terminal ulcer, which is in the regulations. These are when you get an F686 tags. These are the other tags that the surveyor has been instructed to look at. And the provider's role, we kind of talked about that. So F686 should be read in detail. We talked about that. And the pressure ulcer injury program, it requires knowledge, which you've been doing for the last 12 months. I'm so impressed with all of you that have shown up month after month after month. You have to have knowledge. You have to have policies. Where are your policies for pressure injury prevention and wellness? You have to have consistent, accurate assessments, documentation, and reporting. We have to have a plan of care that we're using current evidence-based interventions. We need to monitor those interventions and change those interventions as that resident's or patient's clinical conditions change. So these are your references. This is the end of your 12-month curriculum. Thank you, thank you, thank you. If you've done one of these, if you've done 12 of them, all of them in between, thank you for being here. I want you to go forth and provide stellar wound prevention and management, grounding in evidence, guided by the professional standards, framed by CMS regulatory guidance, and always centered on the people entrusted to your care. Thank you. We're done, Jacqueline. I'm 4 minutes late, so sorry. Thank you, everybody.
Oops, sorry about that. I was trying to get my camera on. Thank you so much to everyone for being here. Thank you as always, Pamela. You are wonderful.
Thank you, sweetheart. I appreciate it. It's a hard one. This was a hard one, y'all. This isn't the easy peasy one with lots of pictures. This is deep, deep, deep. And thank you for staying. I'm going to jump off and go to my next meeting.
Sounds good.
Thank you, Jacqueline. We'll talk soon. Let's talk by next week, okay?
Okay.
Right.
Sounds
good. Thank you, everyone.
Bye.
Appreciate you. Bye-bye.